and we have speakers from actually 3 continents, and I think it's going to be very exciting to hear from them. So we've got 3 speakers tonight. All of them are extraordinary in their fields. We're starting with Dr. Amr Hani Safwat, anesthetic and intensive care consultant. Dr. Safwat is currently the head of the Anesthesia and ICU department in Treetop Hospital in the Maldives. He completed his training at Ain Shams University in Egypt. He augmented his knowledge and experience by attaining master's degree and doctorate degree from the same university, as well as the membership of the Royal College of Physicians. Dr. Safwat has got extensive experience in intensive care medicine and was the head of the intensive care at the Ghassan Naguib Faroun Hospital in the Kingdom of Saudi Arabia for 10 years. With this arsenal of experience and knowledge, Dr. Safwat will take us tonight. Will talk to us tonight about obstetric emergencies, focusing on the recognition and management. Followed by that will be Professor Ansari, who doesn't need an introduction from me, Professor of Anesthesiology and Intensive Care Medicine at Ain Shams, our appreciation for his generous gesture to share with us his comprehensive and unique knowledge and experience. Because from now on, Professor Ansari will be giving us a short focused presentation every Sunday about a topic in the intensive care medicine. Again, I can't thank you, Professor Ansari, enough for being with us tonight. And last but not least is Dr. Alojo. He's a consultant anesthesiologist and interventional pain specialist. Dr. Alojo is currently the Director of Chronic Pain Management Service at Horizon Health in Canada. He completed his training in Ireland and completed multiple degrees and international qualifications in pain medicine and interventional pain procedures. He teaches on multiple local and international forums, including the American Society of Interventional Pain Physicians, Pain Network in Africa, and the International Pain School in Budapest. And we're very lucky to have him tonight to talk about Enhanced Recovery Program, the basic principles and implementation challenges. And now, without any further ado, I'll give the microphone to Dr. Safwat so he can start his presentation.
Thank you for giving me this opportunity again to share some of the experience that I can give to all of you. Thanks you for the organizing committee, Dr. Saad, Dr. Walid, Dr. Walid Aswa, Dr. Hisham, and Dr. Ridi. I'm very grateful for this opportunity, and I'm very honored today to have this chance to speak with attendance of my professor, Dr. Samir Ansari. He's one of my the people who taught me a lot, and Dr. Tolu from Canada. It's an honor to meet you, sir. We will be talking about a very big topic that needs a lot of time, which is obstetric emergencies. So 2 points I want to mention before starting this presentation, that this is not anesthesia for obstetrics. It is obstetric emergencies. When there is an emergency, how to manage and what to do at that time. Second point is that this is the part 1 of the presentation. It's talking about the operative management. There's another part will be talking about the intensive care part and how to deal with the intensive care. So during pregnancy, there are physiological changes happening in the lady system. We have increase in cardiac output, increase in heart rate, increase in stroke, decrease in systemic vascular resistance. So increase of cardiac output, it will be overcome by the increase of systemic vascular resistance. So blood pressure should be maintained. There is decrease in the pulmonary vascular resistance also. Here albumin is diluted, so we can have decrease of the plasma oncotic pressure, can cause pulmonary edema at lower pressure. The gravid uterus is bulky, making aortic compression, decreasing the venous return. You can hear a physiologic third heart sound, which is considered normal. What happened in the respiratory system? Mean volume increase, tidal volume increase, PCO2 level is maintained, level of 27 to 32. There's some renal compensation, allowing compensation to keep the pH slightly alkalemic, not high, decrease functional residual capacity, and increase oxygen consumption. Both increased oxygen consumption and decreased functional residual capacity can cause more rapid desaturation during episodes of hypoventilation. That's why we should be very careful in giving good pre-oxygenation for the patient. Blood changes that are happening, there's increase in the red cell volume of 20 to 30%. Plasma volume also increased more, so causing dilution hyponatremia. There's a hypercoagulable state with increasing fibrinogen and some clotting factors, leading to higher possibility of blood clotting. And in the GIT, there are two important changes: the decrease the lower esophageal sphincter tone will increase risk of aspiration, and there is also increased time of gastric emptying, which also helps in aspiration if ever. Renal changes, we have increase in the glomerular filtration rate, reducing plasma urea and creatinine, and in some centers, they're saying that normal urea and creatinine in pregnant patient is a warning sign. The epidural space, there's decrease in the epidural space due to stented venous plexus, reducing the volume of local anesthetic needed and increasing the risk of epidural vein catheterization. So making aspiration before injection is important to avoid any intravascular injection. So what are the obstetric emergencies that we can meet? Number one is the major hemorrhage, which with blood loss above 1,500 ml or drop in hemoglobin level more than 4 grams per deciliter. Antepartum or postpartum. 2, hypertensive emergencies during pregnancy, preeclampsia and eclampsia, or fetal distress. So these are the major things that you will meet as emergency that you have to deal in quickly and fast, and to be competent enough to deal with this. What's antepartum hemorrhage? Antepartum hemorrhage is the vaginal bleeding after 20 weeks of gestation, which can complicate 3 to 4% of all pregnancy. This is the leading cause of antepartum hospitalization, maternal morbidity, and the need for operative intervention. Placenta previa. This is the condition where the placenta is implanted in the lower segment of the uterus, ahead of the presenting part of the fetus. Its incidence is about 1 in 300. Presents with painless vaginal bleeding occurring near the end or after the second trimester. There is also placenta accreta and placenta percreta, where the placenta is implanted in the myometrium or even out can penetrate the myometrium. Placental abruption is the premature separation of the normally implanted placenta. Bleeding can be either painful vaginal bleeding or can be concealed in a retroplacental clot. The significant blood loss and the loss of continuity between the maternal and fetal circulation can compromise fetal oxygenation. So it can compromise both the mother and the fetus. Risk factors for placental abruption: hypertension, age above 35, multiparity, smoking, premature rupture of membrane, and abdominal trauma to the pregnant lady. Uterine rupture. Uterine rupture can be caused by abdominal trauma, previous uterine surgery and grand multipara, fetal macrosomia or malposition, or short time since last CS with induction of labor. All these factors can increase the incidence of uterine rupture. Postpartum hemorrhage. Here, our friends, the OB/GYN doctors, have a very well said saying that antepartum hemorrhage weakens the patient, but postpartum can kill. So postpartum hemorrhage is one of the major challenges that will meet all people working in the labor room or in the operative theater. So what are the causes of postpartum hemorrhage? It is the 4 T's. Tone, trauma, tissue, thrombin. Tone is the atonic uterus, loss of uterine tone, common with placenta previa, multiple pregnancies, polyhydramnios, previous history of postpartum hemorrhage, obesity, prolonged labor, or elderly primi gravida. Trauma to the genital tract is post-CS, mediolateral episiotomy, operative vaginal delivery, and delivery of a neonate above 4 kilograms. Tissue means the retained products of conception. If the not part of placenta is retained, a blood clot, all this can cause uterine atony and bleeding. Any coagulopathy. DIC can develop early after massive placental abruption or amniotic fluid embolism. What would be the clinical findings? My clinical findings here is divided into 4 categories according to the amount of blood loss. Starting from compensated, mild, moderate, or severe. Here we will see the changes in systolic blood pressure, and you will see the symptoms and signs increasing more. So you have to deal with the patient according to the clinical condition that you are seeing. The pregnancy-induced hypertension. Here we have preeclampsia, which is happening for 2 to 3% of all pregnancy, and eclampsia with less prevalence. What are the associations of preeclampsia and eclampsia? It is primi gravida, multiple gestations, obesity, age above 40 years, previous history of preeclampsia or positive family history for preeclampsia, chronic hypertension or chronic renal disease, and some kinds of autoimmune disease, which is considered as some pathology of preeclampsia and autoimmune reaction between the mother and the trophoblast of the fetus. The clinical definition of preeclampsia is the elevated blood pressure with systolic above 140 or diastolic 90 on 2 occasions 4 hours apart in a previously normotensive patient. And proteinuria more than 3 grams in 24 hours. Or symptoms like systolic blood pressure above 160, diastolic above 100, thrombocytopenia below 100,000, liver function test is more than double normal or severe persistent upper quadrant or epigastric pain, serum creatinine high or doubling of the level of creatinine, presence of pulmonary edema, or new visual disturbance or brisk reflexes. All this are the signs of preeclampsia. Before, the definition was more easy. It was hypertension, proteinuria, and edema. But now they made this more clear definition. What are the pathological changes that we will see in preeclampsia? The airway, there will be facial and laryngeal edema, which will cause difficult intubation. Cardiovascular system, there is decreased cardiac index, increased systemic vascular resistance, decreased pulmonary capillary wedge pressure due to the contraction of the intravascular volume by 30 to 40%. Here, if we give a flow challenge, it might improve the CVS stability and increase cardiac index, but this should be done very cautiously to avoid the evolution of pulmonary edema due to low oncotic pressure. What will happen in the central nervous system? We will have cerebral vasospasm, microinfarcts, petechial hemorrhages, causing CNS irritability, visual disturbances, headache, and can progress to convulsions. Coagulation problems, thrombocytopenia, DIC is not uncommon in severe preeclampsia. Renal disorders, decreased glomerular filtration rate or acute tubular necrosis. HELLP syndrome, which is one of the major complications, it is hemolysis, elevated liver enzymes, and low platelet syndrome. So now we are having an emergency. What is the degree of urgency of this CS? When we have to interfere? Many classifications happened to this to classify the urgency of CS. One of the mostly common or mostly widely used is the Van classification, which was done in 2009, where in category 1, there is an immediate threat to the life of the mother or the fetus. We have to end this pregnancy within 15 to 30 minutes. Placental abruption, uterine rupture, or cord prolapse. Now, category 2, maternal or fetal compromise that is not an immediate threat to life. It can happen in 30 to 60 minutes, like breech presentation, previous CS in labor, or non-reassuring fetal status, hypertension during pregnancy. So the degree of urgency of CS. So there was many classification to discuss the urgency of CS, how to categorize it. The Van Dellen classification, which was done in 2009, classified it into 4 categories. Number 1, immediate threat to the life of the mother of the fetus, which needs baby to be out within 15-30 minutes, is placental abruption, uterine rupture, or cord prolapse. Number 2, maternal or fetal compromise that is not an immediate threat to life. It takes 30 to 60 minutes for baby out, like breech presentation, previous scar, and previous CS in labor, and non-reassuring fetal status. Number 3, the mother needs early delivery, but there is no maternal or fetal compromise. And number 4, time to an elective CS, which is done for elective cases. How to give the timing of the delivery. So decision to deliver interval for CS. So category 1 should be less than 30 minutes. 30 minutes means the time from decision to baby out. So as it's something like the door to injection time or door to balloon time in the acute myocardial infarction. So these 30 minutes are divided to 5 minutes for transporting the patient to the OT, 5 minutes for draping and painting, and the remaining time is for anesthesia and delivery of the baby. Decision to deliver interval for CS category 2 is 30 to 60 minutes, so we have more time to, and you will do some blood investigations like full blood count, blood grouping, and cross-matching is highly recommended. Intravenous induction agents that we will use at that time, still many centers recommend the use of thiopental, 3 to 5 mg per kilogram for induction with succinylcholine for induction. Other drugs can be used for induction, etomidate and ketamine. Ketamine is still preferred in cases of severe shock or fall is not very popular due to its associated poorer neonatal profile as proved by some studies, and the shorter duration of amnesia, which leads to patients' awareness at some time with longer time of recovery of spontaneous ventilation. Cricoid pressure is highly recommended during intubation. Pressure should be directed perpendicular to the tilted table at the level of C6 and released only after the cuff of the ETT is inflated. Opioids can be only given after the fetus of delivery due to the effects of the neonate as they are crossing the placental barrier, as we all know. The use of supraglottic airway devices for GA, can be used as a rescue device to maintain oxygenation in cases of difficult intubation. And the second generation supraglottic devices like LMA ProSeal and intubating LMA hold a great potential in the management of airway in obstetric. What I'll do intraoperatively. Minimum monitoring standards recommend ECG leads, O2 saturation and tidal CO2, non-invasive blood pressure and invasive in selected cases. Measurement of urine output is very important. Is maintained by inhalation agent as sevoflurane. Nitrous oxide is preferred by some due to its intraoperative analgesic effect, and extubation should be done when the patient is fully awake. Please take care of this because some of us will make early extubation. If the patient will go to spasm or needs re-intubation, it might be very difficult at that time. Can we use regional anesthesia in category 1 CS? Yes, we can. Now there is a new term called rapid sequence spinal anesthesia. In skilled hand, spinal anesthesia can be as rapid as GA with low failure rate. Rapid sequence spinal is performing spinal anesthesia with bare essentials and limiting the number of attempts. And the drug of choice is bupivacaine with or without fentanyl. So if we decided to go for spinal anesthesia, please always be ready for GA at any time. These are the recommendations about spinal. The third option is the top-up of epidural anesthesia. If the patient has already an epidural catheter in place from the beginning of labor, and then they decided to shift her to rapid CS, as the speed of onset is very important, so the choice of the local anesthetic must be based on the speed of the block. With fentanyl and epinephrine can give surgical block in 3 to 5 minutes. Inject the top-up dose as early as possible, as soon as the decision of the emergency CS has been made, and preferably injected in the labor room before shifting to the OT. Inadequate top-up dose or inadequate time before incision can lead to high incidence of converting the patient to GA. So what are the special considerations that we can make here? In cases of massive obstetric, what we will do? First, we'll have to resuscitate the mother. Assess the ABC as usual, airway, breathing, circulation. Start oxygen 10 liters per minute to maximize the oxygen delivery to the baby. Secure an IV access, ideally with 2 wide bore cannulae with 14 or 16 G. Central venous line if collapsed, patient with difficult cannulation. Keep the patient warm. You can use external warmer. And the corners, until blood is ready, infuse at least 2 or 3 liters of crystalloid. Warm Ringer lactate is recommended. The cornerstone in peripartum hemorrhage is the restoration of both blood volume and oxygen carrying capacity. Here, the clinical picture is my main determinant for the need of the blood transfusion, not the lab. Please use your clinical judgment. Don't wait for the lab results while you are seeing the patient deteriorating in front of you. Use your clinical sense, use early blood, it will be very helpful. Compatible blood in the form of red cell concentrate is the best option, if not available, so uncross-matched group and RH specific blood, or at least is O negative blood in life-saving conditions. 4 units of FFPs for every 5 units of RBCs. If PT or if PT and PTT is more than 1.5 times the normal values. Platelet concentrate if platelets is less than 40,000, and cryoprecipitate is if fibrinogen is less than 1 gram per liter. The British Committee for Standards in Hematology determined the minimal therapeutic goals of management of massive blood loss is to maintain hemoglobin more than 8, platelet more than 75,000, PT and less than 1 time of mean control, and fibrinogen is more than 1. Still, the golden rule in treatment of massive peripartum hemorrhage is the blood and blood products. Yet, in cases of intractable PPH with no other indications of hysterectomy, recombinant factor 7A should be considered before hysterectomy with a dose of 60 to 90 microgram per kilogram, can be repeated 20 to 30 minutes based on the clinical response. And now it's used in many centers, and it's some good recommendations are given about it. As we are used to give oxytocin and ergometrine for these patients, we will still go on using them. Second important problem that we are meeting in emergencies for delivery is the management of preeclampsia. We have many problems how to solve them. Number 1, prevention of years, magnesium sulfate is the drug of choice still, and it will be, I think. Preeclamptic patients allocated to magnesium sulfate have 58% less risk of an eclamptic seizure than patients not given magnesium sulfate. Loading dose of 4 to 6 grams over 15 minutes IV, maintenance dose 1 gram per hour for 24 hours, with target serum concentration of magnesium 2.52 to 3.5 millimole per liter. And checking the plasma level of magnesium is very important. Magnesium sulfate causes generalized CNS depression, cerebral vasodilatation, mild antihypertensive effect, and tocolytic effect. What is the fluid therapy recommended in preeclamptic patients? Preeclamptic patient with oliguria may benefit from good volume loading, although we should be very careful during doing this because of the low colloid oncotic pressure and the risk of pulmonary edema. So give fluids with care, be guided by the urine output, be guided by the general condition of the patient. Don't overload the patient. How to manage the hypertension in preeclampsia? The objective of antihypertensive therapy is to prevent cerebral complications as encephalopathy. The only known treatment of preeclampsia is the delivery of the fetus and the placenta. So immediate delivery is appropriate when there are signs of impending eclampsia, multi-organ involvement, fetal distress, or gestation above 34 weeks. The threshold of treatment is systolic pressure above 160 and for diastolic above 110. What are the drugs used for treatment of hypertension? The betalol can be used as IV bolus or infusion. Hydralazine, calcium channel blockers should be used with great caution due to the exaggerated hypertensive effect if used in combination with magnesium sulfate. Angiotensin converting enzymes and ARBs are contraindicated in the treatment of preeclampsia. And this is the main points of treatment of hypertension. I think my time is about to finish. So we will pass to the second issue is the category 2 and 3 and 4 CS. As these are not top emergencies, the technique of choice of induction of anesthesia is anesthesia, and preparation to convert the patient to GA should always be available with expected airway management. I hope this was not a very condensed lecture. These are some photos of the Maldives. And with this, I thank you very much, and I thank the organizing committee, and hope we can give another presentation about the ICU management of obstetric. Thank you so much.
Thank you very much, Dr. Amr. It was really a great presentation, and the pictures are amazing. We're all jealous, being in the lockdown here, not being able to see all that beauty.
So for people not to be jealous anymore, I'll stop the sharing.
No, thank you very much. Thank you.
Thank you.
We have a few questions. Starting with the first question is: can we do rapid sequence spinal before we have coagulation studies?
Yes, we can. With the very small needles that we have now, and I think it can be done without great fear. We're not using the 20 or 18 needle as we were using before when we started our training.
And I can add also something, if I may, is that the guidelines in the UK also doesn't specify any special investigations if the patient is presenting emergency, as long as there's no history of any coagulopathy or any presentation was you may fear that there would be some coagulopathy with that. Also, there are other questions. Regarding the rapid sequence induction in CAT1 sections, you mentioned the use of thiopentone and SUX. What about the use of propofol and rocuronium?
Propofol is, I already mentioned about the propofol. It can be used, but there are some studies talking about that propofol has some poor neonatal outcome. So some centers are not recommending it. Procronium can be used, but today I mentioned the thing that it's available everywhere. We all know that in some places in Egypt and in our places, the procronium is not available.
Last question. There's a question here from Mohammed Imam. How many units can we give O negative if the patient, if her blood group isn't ready? And if we give her O negative, can we give her own blood group afterwards? So it's like, if we give O negative, can we cross match her and give her the cross match blood afterwards? And how long between the time of giving O negative and giving her like the cross match blood we have to wait?
Okay, so this is a very complicated question. Usually we will give the O negative or the uncross matched same group in the life-saving condition. The patient is in a very bad condition, so we can give. I never had any reference of giving more than 1 or 2 of this units. And yes, we can give her own blood after that, but really I don't have an answer about the time lapse between the O negative and the blood group. So I can check this one and I'll answer you back.
Right, thank you very much for that.